extremity, pain management, upper extremity surgery. So the opioid epidemic has really been in the headlines for the past several years, and it's really caused providers to have conversations to kind of rethink how they manage pain. Today, we'll be looking at some various strategies that we can employ to do this. Here are some objectives for today's talk. And we'll go ahead and get started with some background information. And just for some context, this graph here on the left shows New Jersey opioid-related deaths in June of 2021, about 287 deaths total in June. Middlesex County accounts for about 23 of these deaths, and we have about 1,600 in 2021 so far. In the same time period in June, we had about 155 COVID deaths. Now, granted, these numbers, as you can see in this graph on the right, are not during peak COVID spikes, but to some extent, it has kind of overshadowed the opioid epidemic in today's landscape, and it still is a real and existing issue. Although there are many factors, one contributing factor to the epidemic has been opioid prescribing habits. In 2010, the US saw its highest prescribing rates at about 782 morphine milligram equivalents per capita. This has decreased to about 640 in 2015. However, if we look at the graph on the right, the number of day supply has increased from about 13 to 17 over the course of 10 years. Again, there are many contributing factors, but there are a few important key players to recognize in the healthcare system. In 1980, Porter and Jick published a paper in the New England Journal of Medicine, and they basically stated that addiction was rare with narcotic treatment. They looked at about 40,000 patients that were hospitalized, and about 12,000 of these patients received at least one narcotic preparation. And they only had 4 cases of documented addiction in all of these 40,000 patients. Again, the criteria for opioid use disorder has changed over the years, but this really made it widely acceptable to use narcotics for pain management. Additionally, in the late 90s and early 2000s, the American Pain Society and Joint Commission came up with pain management standards, and the concept of pain as the 5th vital sign. So just like a nurse would check a patient's heart rate, or blood pressure, they would check their pain scores, and you would have to treat pain just as you would treat any other vital sign. If your blood pressure was elevated, you would get an antihypertensive. If your pain was elevated, you would get some sort of pain medication, possibly a narcotic. And this really played an important role in how providers practiced. This played a role in patient satisfaction scores and hospital reimbursements. So the goal was really to control patients' pain as much as possible. In addition, the legal landscape really made it easier for providers to just provide a few extra pills with each prescription. There were some barriers to providing these medications. For example, here in New Jersey, for a very long time, patients required a hard copy of the prescription to be able to fill any scheduled narcotic medication. So in order to prevent additional visits or additional calls, it was just easier to go ahead and give a little bit extra. And again, the intentions were pure, but it did have some negative effects. Now, the pendulum has swung. We've all made a cognizant effort in recent years to be more intentional in our opioid prescribing and to find innovative ways to manage pain. And that's kind of what we'll be discussing today. So today we'll go ahead and split up our pain management strategies into 3 sections and these time periods of intervention. We have preoperative, perioperative, and postoperative. Preoperatively, we'll focus more on patient counseling and patient education and the role that plays in the way patients manage and experience their pain. Perioperatively, we have many multimodal pain strategies, and postoperatively, patients ultimately do need medications to control their pain and opioids, but we can have some evidence-based opioid prescribing. As we move forward, we just want to keep this analgesic and pain pathway in mind. So pain generally starts peripherally with a noxious stimuli to the peripheral nociceptors. This is transmitted through peripheral nerves up to the spinal cord and eventually up to the brain where it's processed. And we can target pain at different points in this pathway. And again, I think it's important to note the difference between nociception, which is the signal to this noxious stimuli that travels to the brain, and pain, which is the perception and reaction to the stimuli and how we experience it. So as you can see, a lot of these medications listed on this chart really act at various locations. For example, local anesthetics, depending on where we administer them, can act peripherally on the peripheral nociceptors. They can act on peripheral nerves, spinal cord. And we have medications like opioids that can also act on various locations. We'll also touch base on NMDA antagonists shortly later in this presentation that work centrally in the spinal cord. And I just want to point your attention here to this line that's going from the brain down to the spinal cord. It's labeled descending modulation. And this is a really important area that we can target in the preoperative setting, which we'll get into shortly, through cognitive behavioral therapy. So again, nociception is the signal to noxious stimuli and pain, and noxious stimuli and pain is the perception or reaction to the stimuli. We have kind of the ability to also modulate it with this descending modulation in CBT. So we'll go ahead and dive into some of these preoperative interventions. And interestingly, patient factors really play a very important role, which I'm sure is not really surprising to many of us. Postoperative pain is actually not necessarily the largest contributing factor to developing an opioid use disorder. A lot of patient factors may contribute to this, including tobacco use and substance abuse disorder, mental health and anxiety, mood disorders. Additionally, pre-existing chronic pain really plays an important role in pain catastrophizing. We really see in a lot of these patients that we interact with that have chronic pain and maybe have a lower pain threshold, they have a harder time controlling their pain postoperatively. And a lot of times this information will come out during the history and physical, during office visits, but for others, it may be a little bit less apparent. So there are ways that we can kind of screen patients for this. The AAOS actually recommends the use of these preoperative screening tools to identify patients that could benefit from preoperative counseling or other interventions. There are these two questionnaires, the Pain Self-Efficacy Questionnaire and the Patient Health Questionnaire. And they basically look at patients with low scores that may have trouble and identify them as patients that may have trouble managing their own pain. They may benefit from psychological intervention to develop more effective coping strategies. And again, this is in line with the descending modulation that I was pointing out on that pain pathway earlier. If we can help patient with cognitive behavioral therapy, altering the way they react to the noxious stimuli, we could potentially alter the way they perceive the stimuli and ultimately their pain. And these are very short surveys and very short questionnaires. The Pain Self-Efficacy Questionnaire really asks patients to rate how confidently they feel that they can still accomplish most of their goals in life despite the pain they're experiencing, and the fact that they can still live a normal lifestyle despite their pain. The Patient Health Questionnaire looks at whether or not patients have had little interest or pleasure in doing things, or if they've been feeling down or depressed. And again, identifying these patients as patients that may benefit from preoperative intervention. There's also this opioid risk tool for narcotic abuse, and it looks at family history, personal history, and a few other factors. And the higher the score, the higher the risk for opioid abuse. Now, in addition to these preoperative screening tools, it's very important to have conversations with our patients and set expectations for pain. No surgery is without pain, and patients do need to understand that. And sometimes they may not always understand that concept going into surgery. So this study published in 2020 in Hand looked at preoperative counseling on postoperative opioid consumption after upper extremity surgery. They had 131 patients. They showed them a 5-minute video. And this video basically reassured patients that opioids are safe when prescribed appropriately, and that the team really is there to help them throughout the postoperative period to help manage their pain. They did find a decrease in opioid consumption in the group that underwent counseling. What's interesting is that even with this counseling, we still had over 1,800 leftover pills in this small group of 131 patients. It's also, I just wanted to bring it to everyone's attention, the AAOS has a lot of great resources, which we'll kind of touch on later, but they do have a 4-minute video that kind of describes this concept of nociception versus pain and kind of setting expectations for postoperative pain that may be helpful for patients. So, some of the preoperative interventions that we talked about really mostly revolve around counseling. This kind of involves discussing expectations regarding pain, seeing how they've responded to pain in the past and surgeries in the past, and really coming up with an individualized plan for each patient. Some patients could benefit from CBT therapy and other interventions, and this could be a helpful tool in specific patient populations. So moving on to perioperative interventions, we'll go ahead and get started with the patient case. we can go ahead and try to use Nearpod. We have the code here in the top left corner. It's a VAH3I. Give everyone a couple minutes to join. And if you're not able to use Nearpod for any reason, we definitely welcome any other input on the Zoom chat. All right, while everyone's logging in, why don't we have one of our medical students read the question here? Great. All right, so I apologize. We're having some difficulty bringing the results live onto the screen, but I have the results in front of me. A lot of people are picking C, supraclavicular block. We have general anesthesia coming in second. Kind of even right now. And it's important to also mention that there isn't necessarily a right or wrong answer in this situation. I think each patient can have an individualized treatment plan, and all of these definitely have their role in the perioperative setting.
So, Dan, just to clarify, are you talking in this particular case? Are you talking about purely intraoperative pain control for an hour and a half, or are you talking about postoperative pain control with a long-lasting block?
Intraoperatively for this patient specifically undergoing surgery. So would we do general anesthesia alone, a block alone? Or if you recommend a combination of the two, we can do that too. Right, great. So it looks like a pretty even split between general anesthesia and a supraclavicular block. So we can go ahead and discuss this a little bit further. Peripheral regional blocks are something we're all very familiar with, and they've been around for a very long time, and they've continued to evolve, become more effective over time. We have three major blocks that we use in the upper extremity: interscalene blocks. This really targets the root trunk level of the brachial plexus. It's great for procedures in the shoulder, proximal humerus, distal clavicle. Supraclavicular and infraclavicular blocks really kind of target the same locations: the arm, elbow, forearm, hand. But they target different spots of the brachial plexus. So supraclavicular, we're looking more at the anterior, posterior divisions of the trunks, and infraclavicular, we're targeting the cords right before the axillary musculocutaneous nerves branch off. And again, these are great options for patients. There are some complications, including pneumothorax and some nerve blockade, including the recurrent laryngeal phrenic sympathetic chain. And these may require some management depending on the severity, but generally they're relatively safe, especially when performed by an experienced provider. Moving forward, there's also IV regional anesthesia. So this is commonly referred to as a beer block. The idea is we place a tourniquet above the elbow and provide arterial occlusion. The arm is exsanguinated, and anesthetic agents are injected into an IV cannula distally in the arm. And the idea is that this anesthetic will provide a regional effect distal to the tourniquet. What's important to note is once the tourniquet is let down, whatever residual local anesthetic is present in the extremity will diffuse systemically and can provide or can have systemic adverse events like seizures, cardiac arrest, and other complications. So minimum tourniquet times are required. And this is quoted in the literature to be anywhere from 20 to 30 minutes. Some studies have looked at ways to kind of decrease this time by using a forearm block and a smaller amount of local anesthetic. And this study looked at by Arslanian et al. Looked at 121 procedures, and they were able to decrease the tourniquet time to about 10 minutes. So again, this is a really great option, but we have to tailor it to the type of procedure that we're doing. And one of the things that we've also been using is this concept of wide awake surgery. The idea is we can use purely local anesthetic into the surgical field. And the great thing is for patients with multiple comorbidities that can't necessarily undergo surgery, we don't need pre-op clearance. It's also great for patients, especially in the setting that we can provide them with education intraoperatively, and we can have them participate. So with patients undergoing trigger finger releases, we can have them actively move their fingers and make sure we've completely released the pulley. And it's a great way to have them also understand what's going on during the surgery and have good expectations post-operatively. It's also nice because there's minimal PACU care and patients can generally go home sooner. This one study looked at 100 carpal tunnels done with only lidocaine and epinephrine versus carpal tunnels done with IV sedation. And both groups were happy in the end, but the wide awake patients spent less time at a hospital than sedated patients and less required preoperative testing. Anxiety levels were also lower in the wide awake surgery patients, and they did end up using less narcotics overall. So we have a plethora of local anesthetics. So the question is, which ones do we use? So we have short acting, intermediate acting, and long acting. The short acting chlorprocaine, I have not really seen used so much for the most part, especially for small procedures. We use lidocaine very frequently. It has a quick onset of action, about 5 minutes. It can last anywhere from 1 to 4 hours, and it's great for short procedures. Bupivacaine is a longer acting medication. Again, relatively quick onset of action, can last anywhere from 10 to 14 hours. Great for postoperative analgesia and peripheral nerve blocks. It can sometimes be used for infusion, but more commonly, ropivacaine can be used for infusion. It's less potent alternative to bupivacaine, slightly longer onset of action, duration is about the same. Now, it's also important to note that these anesthetics can be combined with other medications to produce additional and augmented effects. For example, a lot of times we can add epinephrine to increase the local concentrations. These local anesthetics will create a local vasodilatory effect, and by providing epinephrine, we counteract that and can keep the local anesthetic present in the area and the tissues for a little bit longer. Opioids like morphine can also be provided and mixed in with for local pain modulation effect, as well as Precedex or dexmedetomidine, which is an alpha-2 agonist. This is commonly used for conscious sedation, especially in the ICUs. And the idea is that it can slow nerve conduction. And one last thing I wanted to mention about these is that generally we'll also use buffered solutions. And this involves a little bit more chemistry than the scope of this talk, but the idea is that we can combine it with sodium bicarb and basically bring the local anesthetic into its non-ionized form. And this more readily diffuses into the nerve and provides more effective nerve blockade. So, we have all of these anesthetics that seem to work great, but the question is, we can't keep injecting patients every 10 to 12 hours with bupivacaine. So if only there was a way that we can prolong the effect, and surprise, there is. We've all worked with the on-Q pump, and we're all familiar with it, and anecdotally, patients really seem to like them. They're able to get up sooner and start moving and really get active and out of bed with less opioid requirements, again, anecdotally. This study specifically looked at patients undergoing distal radius, open reduction, internal fixation. It compared single shot versus continuous infraclavicular block, and it looked at mean postoperative pain scores and opioid consumption. And these were all lower in the on-Q pump group, but again, the data was not statistically significant in this group. About 20% of patients actually had problems with the on-Q pump, and it was discontinued. So we didn't really get to see the full effect. Furthermore, if we actually look at the follow-up, they went out to 72 hours. And as we all know, most patients will discontinue this at home within 48 to 72 hours. So we don't have data after the on-Q pump was discontinued. So again, I think this is definitely a great option for patients. It doesn't the data is not necessarily clear on whether or not this works, but anecdotally, patients do seem to benefit from it. And it's definitely a good option to help patients. Now, there could be additional ways that we could try to prolong the effect of these local anesthetics. And some really intelligent people came up with this idea of putting bupivacaine in this liposomal formulation. So the idea is we have bupivacaine nicely packaged into these liposomes, and it creates like a depot effect. This sits in the tissue longer, and because it's lipophilic, it'll slowly diffuse out into the tissues. This type of technology is pretty commonly used for other medications, especially psychiatric medications that don't require daily administration. But the question is, does it actually work? So this study looked at in 2020, the Journal of Hand Surgery looked at elective CMC arthroplasty and proximal mural carpectomy in 52 patients. They did an intra-op injection of liposomal bupivacaine or just regular bupivacaine. They looked at intra-op and post-operative opioid requirements and pain scores up to 4 days. And they found that pain scores and opioid use was similar. So this study does not necessarily state that liposomal bupivacaine or Exparel, which is the brand name, actually works very well. Again, you'll find just as many studies saying it works really well and just as many studies saying it doesn't work any better than regular bupivacaine. If you go to the actual manufacturer's website, they have a plethora of studies and indications for which they say it works really great. Anecdotally, patients do seem to state that they have good pain relief. This can be used for peripheral nerve blocks to provide a longer lasting effect. And patients seem to really like it. But the question is it actually working, or is there something else kind of at play? At the end of the day, if the data is not supporting it one way or the other, it's really going to come down to the cost of this medication. It is still a relatively new medication, so it can be cost prohibitive. Just for some context, a single dose can be anywhere from about $200 to $350, while regular bupivacaine is about $1. So moving forward, we can go ahead and go back to our Nearpod. And we'll go ahead and follow up on our patient. So any of the students want to read this? So again, just to kind of clarify the question, the on-call resident goes and evaluates the patient. There's no concern for anything dangerous going on. The patient's just experiencing some pain. And we're just trying to figure out what the next best step would be to help control the patient's pain.
Where's F? Loosen the bandage.
That's definitely a very important thing to consider. We're assuming that everything is okay on that standpoint, just for the purposes of this question. Definitely very important to consider. All right, a lot of options coming in for B, Toradol. Some responses coming in for Tylenol. PCA. No love for ketamine so far. All right, so the most popular answer is Toradol, and that's great because that's what we're talking about next. So Toradol is a very effective analgesic for many applications. In orthopedics, there's kind of a tendency to avoid it. There's fears that there can be adverse effects on bone healing and effects on bleeding. And there are effects on bleeding. This is known to occur through platelet inhibition. But recent literature actually shows that there's not necessarily a significant effect on actual perioperative blood loss. Again, this literature mostly comes from our general surgery colleagues with solid organ injuries. There's not too much data in the orthopedic realm, so we do need some more research on that respect. But there is some data on the effect on bone healing in the orthopedic literature. So we'll go ahead and borrow some data from our foot and ankle colleagues for this. There unfortunately was not too much information on upper extremity procedures with Toradol administration, but this retrospective review published in 2018 looked at patients who underwent ankle open reduction and internal fixation. They were given Toradol, oral Toradol, postoperatively to go home with, and they had radiographs that were evaluated by blinded foot and ankle surgeons. They had about 280 patients, and all patients eventually did go on to healing. There was a small subset of patients that was slightly delayed, as opposed to 12 weeks. It was about 17 weeks, but in the Toradol group, there were no cases of non-union. And there was no significant difference between fracture patterns, healing, or other complications. This other study in 2020, again, looked at the same thing and found similar results. So again, I think Toradol can be a great medication that we can use for pain control, but again, it has to be tailored for certain patients. And no one showed any love for ketamine, but this medication has really made a reemergence recently, and it's been a very useful adjunct to general anesthesia, rapid sequence intubation. We use it all the time for procedural sedation in the emergency department, and it's been used a lot more recently as a pain adjunct. This medication can be given initially as a bolus and then followed by an infusion. It can be given intraoperatively or postoperatively. It comes in many different formulations. You can give it intravenously, intramuscular, oral, subcutaneously, intranasal, and even rectal. And it acts as a non-competitive NMDA receptor antagonist, and it blocks glutamate. It acts more essentially in the spinal cord. So sounds great, but what does the data say? So this Cochrane review, 2005, actually looked at the use of perioperative ketamine for acute postoperative pain. They had 37 studies, and 27 of them found that perioperative ketamine did reduce analgesic requirements, pain intensity, or both. And it also reduced 24-hour PCA morphine consumption and postoperative nausea and vomiting. What's important to note is, the studies were not really necessarily consistent in how they used perioperative ketamine. Some of them gave a bolus preoperatively. Some of them started off with a bolus and continued it intraoperatively and postoperatively. And they would use it at various time points in the perioperative setting, but the data still supports that it did help with pain. This Cochrane review is not specific to orthopedic procedures specifically, although it did include some. So this study in 2019 looked at low-dose ketamine in what they called painful orthopedic surgery. They looked at joint replacements, spine, shoulder, arthroscopic surgeries, and orthopedic oncology and trauma. Their primary outcomes were total opioid use, time to first opioid, and pain scores. They had about 20 studies, and they found that ketamine did significantly reduce the total opioid use and pain scores at 24 and 48 hours. The results for nausea and hallucinations were equivocal, which is not surprising given the mechanism and the actions of ketamine. And the most prominent effects were seen in total joint procedures. In the arthroscopic procedures, the data was not as strong, but some of the studies did support it. So perioperatively, we looked at some regional anesthesia that can be used and a couple of medications. And again, this is by no means an all-encompassing review, but going back to our discussion on Toradol, I think it can, again, be a very effective medication. It's kind of shrouded in this mystery, and it can be very polarizing for a lot of people. Some people love it. Some people avoid it like the plague. I think ultimately its use should be really tailored individually to patients. For example, patients that have renal issues, or those with GI ulcers or active bleeds or other hemostatic conditions. Those patients are probably patients we should avoid Toradol in. But I think it can be a very useful option for patients that are having trouble controlling their pain or have some sort of aversion or inability to use opioids. Ketamine is also something that's becoming more and more commonly used in the perioperative setting. And again, I don't expect orthopedic surgeons necessarily to prescribe this and recommend this, but we'll probably rely on our anesthesia and pain colleagues to kind of help choose the best route of administration for this. And kind of the great thing about what we just discussed is that we can really combine all of this. So, we can combine general anesthesia with blocks. We can combine it with ketamine. We can combine it with the use of Toradol and other medications as well. So a lot of these medications work well together. That's the whole kind of idea behind multimodal analgesia. So moving forward to post-operative interventions, we have another Nearpod. Any of the students want to read this one out? Some responses for ibuprofen. Tylenol and ibuprofen. One response for Toradol so far. A couple for Percocet.
Tylenol number 3, F. I don't see F here, but Tylenol number 3 with codeine.
Yes, yeah, I should have included that as an option. That's definitely very effective. All right, great. So a lot of responses for A and B. Again, A and B are Tylenol and ibuprofen are great options. Toradol is definitely something to consider. Percocet, I think, can definitely have a role in carpal tunnel surgery, especially in patients that may have had more extensive, neurolysis. Dilaudid, we got no responses for, and I think that's completely reasonable. I think it's a little bit overkill for a carpal tunnel release. So now we'll kind of discuss briefly ibuprofen and acetaminophen. Again, these are medications that are available over the counter, and almost everyone uses them at one point or another. They're relatively safe medications when used in moderation and when used safely according to recommendations, but they aren't without risks. Ibuprofen does have renal effects and effects on with gastric ulcers, and Tylenol can have hepatic toxicity effects. What's interesting about acetaminophen is that it's now available intravenously and orally. A lot of people say that intravenous acetaminophen is a little bit better, and they find that patients respond better to it. The data is still a little equivocal on that, but the concept is that when we give it intravenously, we bypass the first pass metabolism, and we can kind of give a higher dose more rapidly to patients. So theoretically, it may have an advantageous route, but the data does not necessarily support that. So going back to our patient, this study in 2018 in the Journal of Hand Surgery looked at pain management after carpal tunnel release. This was a prospective randomized double-blind study that had 105 patients that underwent carpal tunnel release surgery, and they grouped patients into three groups. And they either received acetaminophen 500, ibuprofen 600, oxycodone 5. What was interesting is they actually had a compounding pharmacy formulate these medications to look identical. So this was really double-blinded. The results showed no difference in pain scores, and they actually saw a higher refill request rate in the oxycodone group. And this is actually pretty consistent with some of the data that we have that supports that pain scores and patient satisfaction does not necessarily have a positive correlation with opioid use. And those who use more opioids can actually have a worse perception of their pain. All right, we have another question. Any of the students? So,
Dan, you keep leaving F out.
oh, sorry about
Tylenol number 3, 20 tablets.
Okay. So again, there's not necessarily a correct answer. I think that's the whole struggle with pain management. All right, so we're getting a lot of responses for B and C. So going through this, Tylenol, again, great option. Is it going to be enough for a patient that underwent distal radius or IF? Probably not. Tylenol number 3, again, this is a great option, but if we look, it's 90 tablets. So the current legislation in New Jersey does not allow us to prescribe more than a 5-day supply as first prescription. We can give them more for subsequent encounters, but 90 tablets, a pharmacy should not be filling that according to current legislation in New Jersey. Oxycodone 5, 20 tablets, sounds pretty reasonable. Percocet, 60 tablets, again, running into the same issue. And OxyContin, so this is the long-acting formulation of oxycodone. It's extended release, and there's a lot of recommendations to avoid this as much as possible, unless you're managing a patient with chronic pain. So how much should we actually give patients? Patients ultimately are going to need opioids postoperatively. There's really almost no way to avoid it, at least right now. So, what is a judicious use of narcotics postoperatively? So this study in 2012, in the Journal of Hand Surgery, looked at opioid use after outpatient upper extremity surgery. And they found that at 2 weeks post-op, the 82% of patients were not taking any medications at all. Only 2% still had inadequate pain management and were still taking analgesics. About half of patients used the prescribed analgesics for about 2 days or less. So, they looked at bone procedures and soft tissue procedures. For bone procedures, open reduction, internal fixation, biceps tendon repair, and rotator cuff repair. The number of pills consumed was anywhere from 14 plus or minus 11. And for soft tissue procedures like carpal tunnel releases, trigger fingers, tendon repair, nerve repair, it was 9 plus or minus 9. So the authors in this study recommended, prescribing 15 pills of a narcotic like oxycodone or Percocet or something similar, and possibly providing 1 refill of a Schedule 3 opioid, which in this case, Tylenol number 3 would qualify. What's interesting, again, we've kind of been touching on this a little bit in some of the studies. In this group of 250 patients, we had 4,600 leftover tablets in just that small group of patients. So again, this other study in 2017, Sports Medicine Journal looked at unused opioid pills after outpatient shoulder surgery. This was a prospective observational study in about 100 patients undergoing outpatient shoulder surgery. They included rotator cuff repair, AC joint debridement and resection, labral repair, stabilization or Bankart repairs. And they looked at the number of unused opioid pills through surveys conducted at 7, 14, 28, and 90 days postoperatively. The data did support that many patients don't actually use all the prescribed opioids, and it results in a large quantity of unused pills. This table here on the left highlights that about 1,600 tablets out of 4,400 were unused. And the table on the right here looks specifically at comparing the different dosages that were administered. So they gave Percocet 5, 325 and Percocet 10, 325. And they found that when comparing the 10 milligram oxycodone dose to the lower dose, more pills of the higher dose were left over. They also showed that a median of 30 tablets were left over of the higher dose compared to 12 of the lower dose. Interestingly, 93% used ice packs and 78% used over-the-counter analgesics like Tylenol and Motrin. So also important to note is 98% of these patients did receive a peripheral nerve block. So, in this setting, there was a large number of unused opioids in this patient population. So you might be asking, what's the big deal? If we give him a little extra, it's not a big deal. They might have it at home. But the concern is what happens to all these medications. And this study in 2014 evaluated this question and found out of 125 patients, 65% of them saved the opioid medications despite not using that anymore. 30% reported using all of their pills or disposing appropriately of the extras. 34% showed some evidence of diversion or sharing their medications. This included illegal diversion. Some patients had their pills stolen. Some of them shared the medication with family or friends, and some of them received extras from family or friends. So, we have data that shows that substantial quantities of pills are kind of out there, and this again shows us that it can end up in the wrong hands. And in this specific study, about 1/3 of patients had their medication diverted or ended up in the wrong hands. And when we look at the number of pills in the thousands, this really becomes a pretty substantial number. So just to briefly touch on drug disposal options, I have gotten a lot of questions about what to do with this from patients, and there's a lot of information online from the DEA and FDA, and the best option really is to bring it back to a drug disposal location. On the bottom right of the screen, we have locations here in New Brunswick where you can bring the leftover medications and they'll take it from you, no questions asked. If you don't want to do that, there's a list of medications online that show you which ones you can flush down the toilet. Otherwise, you can put it in a unmarked bag and kind of mix it with some water or some soil or something to make it unpalatable. So, as we've reviewed, there's many strategies to help address pain in the perioperative setting. We only went over a handful today, but I think kind of the real benefit can come when we combine a lot of these strategies into a perioperative pain protocol. Currently, at this institution, we have protocols for joints and spine. Patients are given preoperative analgesics, and literature really does support this concept. This study in 2020 in our arthroscopy journal looked at perioperative pain control in various support procedures, including rotator cuff and labrum repairs. It had 141 patients, and preoperatively, all patients received Celebrex, Tylenol, Gabapentin, dexamethasone, and tramadol. Intraoperatively, all patients were given this local anesthetic that was a mixture of ropivacaine, Toradol, and epinephrine. Furthermore, most patients did receive a preoperative block. Postoperatively, patients were placed on this strict regimen that included Toradol, diazepam, gabapentin, Tylenol, and meloxicam. And all patients were given 10 tablets of oxycodone 5 milligrams for any breakthrough emergency pain. So what do the results show? Overall, patients did have lower pain scores and decreased opioid requirements. Their mean pain scores were about 3, and the mean number of breakthrough oxycodone pills that were used was about 2.6 or 3. 45% did not require any, and those patients that did require some emergency use oxycodone were more likely to have some sort of history of anxiety or depression, and were reporting greater pain scores compared with those that did not use any. The most common side effect of this protocol was feeling drowsy, and again, that's not surprising. If we look at the medications used here, diazepam and gabapentin are pretty known to have effects that can cause some drowsiness and dizziness in patients. In 2016, the American Pain Society came out with several recommendations for pain management in the perioperative setting. One thing that they looked at was, these are just some of the recommendations that they had that I thought were pretty applicable to upper extremity procedures and orthopedic procedures in general. Oral opioids were, of course, preferred over IV, and immediate release versus extended release. So using oxycodone or Percocet, for example, versus OxyContin, which is the extended release. And the concern for extended release oxycodone is its risk for abuse, as it can be crushed and used in a way that's not intended, providing higher immediate dose and higher euphoric effect. And and its tendency to be more associated with drug diversion. COX-2 inhibitors like Celebrex were strongly recommended preoperatively. They recommended a dose of about 200 to 400 milligrams orally, about 30 minutes to 1 hour preoperatively. And again, our pain protocols at this institution do kind of coincide with this. They also recommended strongly the use of gabapentin, either 600 to 1200 milligrams or pregabalin, 150 to 300 milligrams. I didn't necessarily go into gabapentin too much, but it does have some nerve modulation effects to try to decrease or slow down nerve signals that are transmitted from periphery. There's a good amount of data supporting the use of gabapentin as well. And these two medications, Celebrex and gabapentin or pregabalin, were shown to actually have significant effects on decreasing narcotic use postoperatively. They also recommended the use of IV ketamine. Their recommendation was to use a bolus preoperatively followed by an infusion. Although this was a weak recommendation at the time, they still did recommend it for certain patient populations. So I also just wanted to briefly mention this resource that I think is great for clinicians and patients. The American Academy of Orthopaedic Surgeons, along with the American Society of Anesthesiologists, have kind of teamed up and created this pain toolkit. They have a lot of great resources that kind of go over their personal recommendations for pain management and multimodal analgesia. And they have a lot of great educational resources for patients. I had mentioned earlier, they have about a 4-minute video that goes over setting expectations for postoperative pain. And they have a lot of handouts and really great resources that kind of explain things to patients. They go over safe storage and disposal of opioid medications. And for physicians, they have those preoperative screening tools that I had mentioned readily available and pretty well put together to make it easy for clinicians to use. And one of the things that they recommend and a lot of societies recommend is creating institutional guidelines for perioperative pain management. This kind of, I guess, becomes more relevant when there's wider variety in how clinicians treat patients' pain. The idea is really just to kind of streamline it and make it a little bit more standardized to prevent wide variations and to kind of have a united front from a practice or an institution. So one thing I just wanted to mention and touch upon briefly, the legal and social landscape has really changed throughout the country in the past several years. Patients are really looking for alternative therapies for pain management. With the legalization of medical and recreational cannabis, many patients are using this for self-medication. So I just wanted to briefly review some of the little data out there that exists. Before that, I just wanted to take a quick survey. Have your patients asked you about the use of CBD products for pain management? Open-ended responses. Couple answers here, yes. More yeses. All right, lots of yeses. Seems like patients are really asking a professional opinion about CBD products, and from my standpoint, I've had many patients ask. And next question. So again, to differentiate CBD from medical cannabis, Has anyone asked you in your practice about the use of medical cannabis for pain management? Have a couple yeses. Fewer than CBD. Have someone saying rarely. So not as much of a consensus here. So again, just to briefly kind of differentiate between CBD, which is cannabidiol, and the active component of cannabis, which is tetrahydrocannabidiol. So THC is the active component, the psychoactive component, and this is what causes euphoric effects and a lot of effects that are not necessarily associated with pain relief. Cannabidiol is theorized to activate the endocannabinoid system. It's theorized to have some anti-inflammatory benefits and pain relief. Can also help with, supposedly, with anxiety, depression, again, without the psychoactive component. And, you know, CBD specifically is available over the counter and online. It can be derived from hemp products, which make it a little bit more easy to obtain because there's fewer regulations. Patients are really using it widespread. I've had many patients ask me, you know, does this work? You know, on the right side of the screen here, we have, you know, from one of the websites of one of the retailers, they're advertising benefits for pain management and recovery, sleep, stress, well-being, focus and energy. You know, they're really targeting and trying to advertise a multifunctional alternative medication. And, you know, as we can see here on the bottom right, there's many different formulations of both CBD and cannabis as it's becoming more widely spread and more acceptable legally in many states. So we have, you know, oral tinctures and oils. There are, you know, other edible formulations. A lot of patients are using this stuff topically as well. Whether or not that actually works, again, the data is kind of lacking right now. But a lot of patients anecdotally say that, you know, topically, it does provide them very significant pain relief. So kind of like Voltaren, which is topical diclofenac, a lot of patients are using this instead. You know, the price is relatively similar in their perspective, and they'd like to use something a little bit more natural. So, you know, there's a lot of questions, a lot of people out there that are, you know, advertising great benefits, but what does the data actually say? And again, I could not really find any data in the orthopedic literature, and most of the data out there is in the setting of chronic pain. But for acute post-traumatic pain, this one study in 2020 in Colorado looked at dronabinol use, which is a synthetic cannabinoid. They used it off-label for managing acute pain following traumatic injury. Many of these patients, coincidentally, did have orthopedic injuries and underwent orthopedic surgical procedures. It was a matched cohort study and looked at patients in a 3-month period in 2017 that were admitted with a traumatic injury. They matched patients 1-to-1 with patients that did not receive dronabinol. They used age, injury, and hospital length of stay. So they really tried to make it pretty equal. The primary outcome was change in opioid consumption over the course of 96 hours. They had 66 patients, 33 in each group, and they initiated the dronabinol within 55 hours from admission. As you can see, there's kind of wide variability, anywhere from 28 to 107 hours. And the patients that did receive it did have a significant reduction in opioid use that was about 9 times greater, a 9 times greater reduction in opioid consumption. And this was statistically significant. Again, you know, the data is very limited, but I think it's important to just mention this briefly because patients are going to be using this more frequently, especially with the changing legal landscape. They're going to be using this to self-medicate and may or may not involve healthcare providers in that discussion. So I think it's important to be educated on the subject and kind of know what research is out there. And, there is a great need for more research. And, based with government regulations, it kind of makes research a little bit difficult in this field, but it's becoming more and more acceptable to research it and see what the actual benefits or potential harms are. So just wanted to mention that briefly moving forward. Dronabinol, it's oral. Yeah, so dronabinol was really developed for chronic pain in cancer patients. So, instead of giving them, medical cannabis, especially in states where it was still illegal, the idea was let's create a synthetic cannabinoid that targets the same receptors without the legal ramifications and without, the stigma and whatnot associated with it. For cancer therapy, it actually has very good data on helping with pain and helping with nausea and decreased appetite. So the data in that respect is very good, but for acute pain, this was really the best study that I could find that did show some support, but again, it was a small subset of patients, 66 patients, and it was various injuries. One thing that was also important to note in this study was that some patients did use cannabis preoperatively recreationally, so that may have also impacted some of the results of this study. Right, so just to conclude our talk today, the opioid epidemic does require a multifaceted approach with multimodal pain management. We talked about preoperative counseling, how we can help develop more effective pain coping strategies for patients. Perioperatively, there's a plethora of different options, including blocks and non-opioid analgesics and adjuncts. However, opioids are still required for post-operative pain control. We just need to use it judiciously and have better data on how much exactly to prescribe. And ultimately, perioperative pain protocols can be very effective, as we've seen in our own institution with certain procedures and as the data shows. So that concludes our talk today, and I'll take any questions or comments.
Dan, I have two questions. First, that was a very nice presentation. Question one is, if you're taking your in-service for wide-awake anesthesia, what's the maximum dosage of lidocaine with epinephrine that you can give for an adult? How many milligrams per kilogram?
Yeah, I forget the exact number. I think with epinephrine, it's 7 milligrams per kilogram, if I'm not mistaken. You can give.
That's correct.
I think it's 7.
It's 5 without the epinephrine. It's 7, and you almost never get to the max because unless you have some huge person. So sometimes they ask that question on the in-service. The other question, which is really I don't know the answer to, and I'm not sure there is an answer, but it's very discouraging. For rotator cuff surgery, which is painful, I mean, I give everybody a block. The block wears off, and it's just a matter of when they're going to get the pain, unless you send them home with a pump. So they're either going to get it in the afternoon or in the middle of the night, depending upon when that block wears off. So we give people Percocet because that's one case that I think Percocet is useful. And the maximum is a 5-day dose, which would be 30 pills. But the pharmacist sometimes refuses to give 30 pills because they use this formula for the morphine milligram equivalents. You discussed it in the beginning of your talk. So what they do is they decide what the maximum morphine equivalence is. And sometimes if you give 10 milligrams of oxycodone, you reach that point in 3 days. So if you have a 250-pound person, you give a higher dose of the medication. And if you have a 100-pound person, you give a lower dose. So for the bigger person, you only get enough for a few days. How do we eliminate this problem? Why are they basing it on maximum morphine milligram equivalents and not taking into account the size of the patient?
Yeah, that's a really interesting point. So unfortunately, there's not really a great solution to that. I think that's really going to involve a lot of lobbying and involvement on the legislation aspect. But I think one of the things that we learned about in pharmacy law, for example, was before we could prescribe narcotics electronically, what they would do is since the limit is 30 days, you could provide the patient with, 2 or 3 prescriptions and just post date it. So the patient would, go to the pharmacy, fill the first one. After 30 days, go to the pharmacy again, fill the next one, and so forth. And that was kind of the way that, they would get around the whole limit of, 30-day supply, no refills, and it had to be a hard copy prescription. So that may be a way to kind of get around it. It's not really the ideal way. I think, definitely we need some better legislation for that.
Every other drug has a maximum amount like lidocaine that you can give per kilogram. And someone made this law who knows nothing about medicine and makes it very difficult. So when you have a big person, you're in jam, because after 2 or 3 days, when you use up the prescription, it's a nightmare to get a renewal on Percocet. And again, that's why I think people write for the maximum dosage, is because it's a hardship. They've created a hardship to give someone a renewal for a couple of more days. So I don't think you're ever going to get rid of this, issue with leftover pills, because I think people do it because they don't want to get phone calls for another day or 2 of medication and have to go through, an obstacle course in order to renew the prescription.
Yeah, I completely agree with that. I think the legal landscape definitely, presents a challenge. I think it's gotten better, but there's definitely a lot of progress to be made. And your comment on people that are not necessarily involved in healthcare making these decisions, I think that's a very common issue in healthcare legislation.
And while I'm still on here, I know you mentioned in the beginning that this crisis occurred, in the 1990s or 80s, and probably the government was mostly responsible. But I just wanted to, you didn't make it clear, is over the past 4 or 5 or 6 years, the problem with illegal drugs has now superseded problems through legal prescriptions. In other words, the doctors aren't any longer the cause of this crisis where we might have 100,000 deaths this year from opioid. It's now from illegal production of fentanyl, morphine, heroin, mostly coming through the southern border. So if you look at the problem in the 1990s created by the government, maybe they're responsible because we're letting this crap come in, and it's not really us in the prescriptions. I mean, we're still part of the problem, but a smaller part. So the doctors aren't the main problem right now.
Yeah, I agree. And I don't necessarily think doctors are to blame. I think everyone initially thought this was safe to use. And historically, it's been used for many, many years, and everyone has thought it was safe. And I think it's just kind of a result of a lot of different factors that kind of contributed to it. And also, Dr. Butler did mention that EMR won't let you post-date prescriptions through electronic prescribing. So I guess that may be an issue, but I guess a workaround would be just providing a patient with a hard copy prescription.
Hey, Dan, Swan here. Great presentation. Just like to piggyback on what Dr. Kirschenbaum was just alluding to say that everyone thought it was safe in the 90s and 2000s. I specifically remember being in orthopedic clinic and in Newark, and the drug reps, I think it was the Merck reps, would come in and give you their little jackets and hats and pens and everything else, and encourage you to use OxyContin. And they showed us cool graphs, pharmacokinetics, pharmacodynamics, describing the lower addiction potential of OxyContin, and basically teaching us how to prescribe medications to our patients. And that really was where some of us learned about these medicines and started using them. And everyone started prescribing these in a similar fashion, with the assumption, erroneous and obviously erroneous assumption, that these medications were not addictive. And I even remember telling patients in the clinic, don't worry, these aren't addictive. That's what I've been taught. Foolish on my part, but everyone else was there as well. And I think a learning point must be that, don't trust what you're hearing from the reps, and use your brain, use your science going forward with whatever it is that what's being peddled.
Yeah.
So Swan, we can blame the current status of Newark on you.
You were there before me, Los.
Good point.
Yeah, thanks, Dr. Swan. I think that's a really good point to kind of mention. It's been in the news for the past several years with all these drug companies, and there's even like some Netflix series about it, and how they've kind of exacerbated this whole epidemic. I think also what's interesting with OxyContin is, perhaps the data that they had was real, but in the setting of appropriate use of the medication, they probably didn't necessarily account for the fact that patients are smart, and they'll realize that if they crushed the extended release tablet, they'll get a faster euphoric effect, and that just kind of spirals, and there's higher risk for diversion in that case.
Remember, you have to be very careful with these patients, because I swear to God, these patients, the really good ones, they are Academy Award-winning patients, and they come in and you believe them, and it's really hard to say no. But like Dr. Kirschbaum says, a good point. You get a 5-day supply. That's it. After that, you need to learn other modalities to deal with your pain. So you really need to learn how to say no. You really need to learn about other things in your armamentarium, and it's really, really hard to say no to these people. But one of the lines I tell these people, which I think is a good line, is, look, if I keep giving you pain medications, you're now going to have two problems: one, chronic pain, and now addiction. Now I've got two serious problems, because the narcotics don't fix your pain; they just mask the pain. So you really need to learn to say no, and you need to figure out different ways to tell them no.
Great point. Yeah. And by the way, just so drug companies and all these companies never tell the truth, but remember, the drug companies colluded with the FDA to get the drug approved.
Hey,
so
Dan,
the government tells you something, those are the people.
Dan, I just want to say that was a great talk. And a point that was brought up earlier is that, if a patient's calling for refill, and sometimes it's, a problem with the narcotics, but it also could be a clinical problem. So, a lot happens in that 10-day period. If, you do the wrist fracture and you say follow up in 10 days, you don't want that person sitting home taking Percocet, and then maybe they call and maybe your partner or your PA is giving a refill, and they might be 40 Percocets in before you see them. So, in my practice, we do a 2-day check just to make sure everything's going well. And then if they call for a refill on the narcotic, I want to see them. I want to see what's going on, because maybe they have an early infection. Maybe they're like, Dr. Kirschbaum said, maybe there's something with a bandage. And then you can sit and explain to them, instead of just that reactionary, let's check this box off and give them more meds, because, that's certainly, you want to get them off as soon as possible.
Yeah, that's a great point. Thanks, Dr. Cott. Good question for you. So the 2-day check, is that an in-person office visit, or is that just a phone call?
That is a PA phone call.
Yeah, that's definitely a great idea and a very important point. So the question was, can we just keep administering Marcaine over and over again? I mean, the short answer is, I guess you could, but it only lasts, about 12 hours or so. So yeah, unless you use Exparel, which does last longer, but again, the data is kind of equivocal on that.
Dan, in your research, did you stumble across anything about coming down the pike about NSAIDs that aren't contraindicated in those on blood thinners or those with heart disease, kidney disease? Is there anything like that out there? Because that would be extremely helpful, certainly in the office setting.
I didn't come across any data specifically, but generally NSAIDs can be, still pretty safe. At least, some of the lower potency NSAIDs like ibuprofen. When we start getting into things like Toradol and diclofenac, those are definitely a little bit more contraindicated. But I think, again, I don't know the exact answer to the question, but I think it would require a more detailed conversation with the patient's cardiologist, for example, to see if they're okay with the patient going on, an NSAID. But generally, ibuprofen is pretty safe, even in those patients.
No. Like in the office setting, I'm telling you, every single day, there's patients who say their cardiologist or the regular doctor will not allow them to have NSAIDs. They may not have NSAIDs no matter what, even if they have a headache, they can't take one. They can take Tylenol, which when that doesn't work, now what are you doing? So it's pretty annoying, I have to say, but they take it pretty seriously, some of these cardiologists. So that's an area of potential study.
Yeah, I'll try to see if there's any data on that. I'm not aware of specific literature, but I'll try to look into it.
TG, I think the Vioxx debacle ruined the future of NSAID research, to tell you the truth. I mean, you were around when Vioxx was around. That we used that like crazy, and everybody loved it. And it was the COX-2 inhibitor,
Great medicine,
and everything like that. But ever since Merck took such a big hit, I haven't heard a peep about it, a new non-steroidal, ever since that debacle. It's amazing that Celebrex withstood that, market attack. I don't see anything. I have never heard of anything.
Do you run into the same problem with trying to prescribe NSAIDs for people, your 70-year-old
sure.
with their, whatever, their AFib and they're on a blood thinner? Yeah, right?
Yeah, I mean, I don't know, Dan, you know more about this than we do, but I mean, everyone says if you're on a blood thinner, something strong enough, like if they're on warfarin or whatever, that they shouldn't be taking any non-steroidals at all. And even when I have patients like that, I ask them, I'll prescribe Celebrex, but tell them they have to call their cardiologist before they start taking it. And I've gotten mixed answers. There's no consistency with the effects of Celebrex, consistency from the cardiologist or whoever's prescribing the blood thinner, whether Celebrex is indicated or contraindicated. I still don't know the answer.
Yeah, I'll definitely try to look into this and see if I find any good literature. But my understanding of this is, in a lot of patients that are on blood thinners, we do still give them aspirin, or cardiologists do still give them aspirin. For some reason, a lot of patients are given, Eliquis and aspirin, even if it's not appropriately being prescribed. So, I guess the concern with, these NSAIDs is there could be a potential thrombotic risk versus there's a increased inhibitory effect on platelets. So, I mean, if they're willing to give aspirin and blood thinners, I'm not quite sure what the concern is with giving like a low potency NSAID like ibuprofen. But I'll definitely try to find some literature, and if I find anything good, I'll definitely share it.
Thanks.
Great. Thanks, Dan.
Thank you.